Hi, everyone. Welcome to the PrecisCa GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Taussig Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. This is a 75-year-old man with a history of non-muscle invasive bladder cancer, has a TURBT, and now has multifocal, these are lung nodules with different pathologies. He's been biopsied. One is urothelial and one is just read as adenocarcinoma. And the question is about where to go next for this patient. And this is actually my patient. This is a man who presented with, a few years ago, urinary symptoms and hematuria, good performance status. His medical history is as listed there. I won't read it all to you, but some clotting history based on a factor V Leiden mutation. Otherwise, some reflux, hypothyroidism, et cetera, as you can read there. Former 25-pack year smoker and a father who died of lung cancer at an advanced age. His oncologic history is about 3 or 4 years ago. He was diagnosed with non-muscle invasive bladder cancer. He got a TUR and then got intravesical BCG. Was followed as is standard with cystoscopy, et cetera. And then 4 years later, presented with a CT scan. And this is my patient. I'm trying to remember why he got a CT scan, and I don't quite remember. But we'll see. I think we'll see pictures of this. It showed a larger lobulated mass in his left lower lobe, a spiculated nodule within his left upper lobe, and some nodularity in his retrosternal space, question adenopathy. If you actually look back on previous scans that were done a few years back, he did have some of this lymphadenopathy, but did not have the lung nodules. This is before I met him. He undergoes a biopsy, both of the left lower lobe mass and the left upper lobe mass. I think we have more full pathology reports later in the case. But the lower mass is carcinoma suggestive of urothelial primary, but the upper just says adenocarcinoma and does not appear the same. And so, Dr. Siegel, maybe you can take us through these images and what you see.
So we have two axial images, one through the lower chest, one through the upper chest. And on the image on the left, we see a fairly well circumscribed, homogeneous, slightly lobulated left lower lobe mass. And then on the other image, we see some abnormally increased soft tissue in the anterior mediastinum. And the left lower lobe mass, the differential is extensive. It could be either a primary or a metastatic focus. But just speaking in terms of general terms, the spiculated masses tend to be more often be primary lung malignancies, and the lobulated ones can more often be metastatic foci. The adenopathy, when you read the history, it waxed and waned. At one point, there was fluid in the anterior mediastinum. I suspect it's metastatic adenopathy. I couldn't say with absolute certainty. Rarely in younger patients, not in this patient who's 75, there can be weird-looking thymic hyperplasia rebound, but I've never seen it in a patient really over the late 50s. And this patient's 75, so I don't think that's what's going on. I think it's probably metastatic adenopathy, and then the left lower lobe mass is probably a metastases. The mediastinum would be difficult to biopsy. The lung lesion would be very reasonable to biopsy.
Okay. Sorry. So let me just actually go back. So again, by the time I met this patient, he had had biopsies of both that lobulated larger left lower lobe mass, and that was at the bottom bullet point, suggesting that did represent metastatic urothelial carcinoma. But the left upper lobe mass was very nondescript, and it did not look the same as the lower lobe mass, and it did not look like urothelial carcinoma. So maybe Dr. Drakaki, I'm going to call on you. We actually took this patient to our Vanderbilt tumor board because it appeared he had two different cancers, although we never want to believe that. We don't have his path here, and we don't have a pathologist, so we're all at a bit of a disadvantage. But what do you think the next step would be for this gentleman?
So I have similar cases, and often when I see something in the lung that is not as convincing, like this case that you think something else may be going on, I always biopsy. And we have seen that second primaries, with the lung being second primary, is very common in GU malignancies. And I recall this patient was also a smoker. So it actually fits the picture. So I typically talk to the radiologist with a question: do you think the lung cancer is isolated, early stage? Can we treat it with curative intent, with the whole idea, if we can keep patients with only one cancer, down the road, 2 years later, 3 years later, they may be eligible for trials for the urothelial histology. So in this case, I will ask our radiologist, do you think the non-small cell lung cancer is really all you see? And then I will go to our surgeons and I will ask them, can you do a wedge there? And if they're stage 1 and we don't need to do anything else, that's great. So then we move on in our systemic therapy for only one cancer.
So Dr. Abra, I'm going to turn you into a thoracic surgeon now. Again, part of the problem is, of course, in these cases, we don't have full films and full pathology, so we're at a bit of a disadvantage. But I think we're pretty convinced that larger lobulated mass is a metastatic urothelial cancer. And at least by our thinking and our pathologists, we thought that was isolated. So let's forget about everything else. And is there a role for metastasectomy in urothelial cancer? We talk about it in kidney cancer all the time, right? But not so much in urothelial. I don't know if you have an opinion on that.
No, I think that's right. I think very, very limited role would be right. In this patient, can I ask, was there anything present in the bladder or the retroperitoneum, or is it?
No. And the patient never had muscle invasive disease, and that's the weird thing. One instance of non-muscle invasive 4 years ago, BCG, and then a clean bladder for up until present day, and that's what was bizarre about this big lobulated urothelial cancer, showing in the lung. So I agree. I mean, I've in 20 years, I think I've done a metastasectomy in urothelial cancer once or twice. I don't have an extensive volume of these patients, but I agree there's some sort of sporadic literature out there. So we're actually still in the process of working this patient up. We actually sent Tempus testing on the pathology to see if there were any sort of characteristic mutations or something that could help our pathologists out. And we'll probably end up going back and getting more tissue, honestly, to try and sort of figure out, do we do a metastasectomy and then potentially treat a primary lung cancer? But it was a bit bizarre, again, given that the patient never had muscle invasive disease and that you don't often see a solitary metastasis from urothelial cancer.
Dr. Rini, though, do they think that the small cell is the early stage and not the metastatic? So instead of talking about metastatectomy of the urothelial, to talk about resection of the primary lung cancer?
I think both will probably end up happening. Yeah, it was not non-small cell, not small cell, but yeah, I think both will probably end up happening. Yeah, and so just to summarize, this is sort of a case in. So I think next step. I mean, again, this is one that I think is all over the map, and I don't think it's a very unusual case, but we sort of felt like we needed more tissue, and we're going to go after that lobulated mass, resect that lobulated mass. And then restage the patient, send Tempus testing, and think about next steps, but certainly a very unusual case.